The title of this session is Idiopathic Refractory Overactive Bladder. What should be next? These are my disclosures. And I think for me, excuse me, it's more properly stated as what could be next. And what I'll do is I will make a case for botulinum toxin. First, we have to decide or define what exactly is refractory overactive bladder, and then I think we can further classify the patients, and I think that's important for this discussion. So we're all aware that today we define refractory overactive bladder as symptoms that are inadequately treated by first-line therapies such as behavioral modification and physiotherapy, or second-line therapies such as medications, antimuscarinics, and/or beta-3 agonists, either due to inadequate efficacy or tolerability. We also have OAB wet and OAB dry patients, and I think that whether or not a patient is incontinent is important in this discussion based on the data that we have. So here is sort of the paradigm in 2013 after first and second line therapies are inadequate. Where do we go next? I think it's irresponsible for me to get up here and argue in favor of a single therapy for every single patient. Both therapies can be appropriate. So I think that the decision on which one to use comes down to some patient characteristics, patient expectations, availability, and economics. So now the case for botulinum toxin, and what I will try and do is use data, relative cost effectiveness, and also the lack of widespread adoption of neuromodulation over the past 15 years. In its first 11 years in the United States, about 40,000 sacral neuromodulation units were implanted in the United States at a time when there really was no competition from any other third-line therapy. So I would say that in that 11-year period, clearly we had an undertreatment of patients with refractory overactive bladder. Now, when I talk about botulinum toxin, I think there are some caveats. There's limited data on OAB dry patients, and all of the large-scale studies that I'll talk about are on patients who are incontinent, so I think I have to start there. There are risks with botulinum toxin that patients must accept. Incomplete emptying requiring temporary catheterization, and although this is acceptably low, a patient must be willing to accept this if we're going to use that therapy, and there is a risk of increased urinary tract infection. We now have a lot of data, and the vast majority of data that is on idiopathic overactive bladder is for onabotulinum toxin A, and this is the toxin that is approved by many regulatory agencies now in 2013. There are large-scale phase 2 trials published by Roger Demikowski and phase 3 trials, and it has been determined that the optimal dose for idiopathic overactive bladder, at least to start, is 100 units. It has the best efficacy versus adverse event profile. Now, clinicians may decide to use higher doses, and that may be off-label, depending on where they are, at their discretion. The data is now quite robust, and there are published data from the 2 large phase 3 trials that have included over 1,100 patients. They all have refractory overactive bladder. They're all incontinent, and data for all overactive bladder symptoms, including urgency, incontinence, urgency, frequency, and nocturia, are included, and there's also patient-reported outcomes and quality of life data. And now, in abstract form, we have seen at this meeting and at the American Urological Association data on the 3-year extension trial. What's nice about these 2 trials that have been published is they have the same cohort of patients, and I believe that the patients that were enrolled in these trials are similar to the patients that we really see and treat on an everyday basis with botulinum toxin. This is data for onabotulinum toxin A, and you can see that in the 2 large-scale trials, each with about 550 patients, the results are very, very similar. These are the 2 primary endpoints, incontinence episodes and the benefit on the treatment benefit scale, showing a good response or very good response versus placebo. If we look at in the 2 trials, the mean change in symptoms, when we look at it compared to placebo in this difficult patient group, we see huge differences between onabotulinum toxin, and placebo for all of the overactive bladder symptoms. 3 to 4-fold differences in response versus placebo. To me, this is very compelling data that in 1,100 patients, we have a therapy that works well. We also have quality of life data, and we see exceptional improvements in quality of life on iQual and King's Health questionnaires. So not only the more objective data of incontinence episodes, urgency episodes, frequency, but also very good and robust quality of life data. There is unquestionably 2 adverse events, potentially, that we need to deal with. And this is the big caveat for this therapy. One is the need to catheterize. And if we look at the 2 studies together, the chance that someone will have to catheterize if they receive a 100-unit injection and have idiopathic overactive bladder is about 6.5%. Not 0, but not all that high. And there is an increased risk of urinary tract infection, although these numbers do not reflect symptomatic UTI, but UTI by definition of bacteriuria and pyuria. This is the long-term data that was presented at the AUA this past year. And what we can see for the 2 primary efficacy variables in the trials, that there's a consistent effect over time. Now, you do see on incontinence episodes in cycle 3 and 4, there seems to be a decrease, but there are very few patients in cycle 3 and 4 that have matured to that level. This was a planned interim analysis, so many of the patients are still in cycle 2 and 3. So this probably is a reflection of some of the more severe patients. But nevertheless, if we look at the treatment benefit scale, nice, steady improvements all the way through. And we see similar results in the quality of life data, and this is something that I presented here yesterday. If we look at the Cochrane review of sacral neuromodulation in 2009, 8 randomized trials were identified. What the review says is that some of these may actually be the same trial and the total number of patients is not reported. There's a possibility of subgroup analysis for certain studies which need to be treated with caution. In many of the studies, some or all of the outcomes were reported in a way that is unsuitable for an analysis in the Cochrane review, mostly because of missing measures of variation. And the overall quality of the studies, unfortunately, was poor. This is Philip's very nice long-term review, and it is a very nice study. And it does show that sacral neuromodulation for some patients is an effective therapy over a period of time. And we can see here that over a 5-year period, it does have, in some patients, quite good results. However, only about 57% of patients had full diary data at 5 years. So there's a lot of patients missing, and there's a lot of last observations carried forward here. So it is somewhat, I believe, an incomplete data set. It doesn't mean the therapy doesn't work. It just means that there's a lot of unknowns for what I believe is a very expensive therapy. These are the conclusions of the paper, that this long-term prospective, multi-center, FDA-regulated study represents the most comprehensive review of sacral neuromodulation with the largest patient population. But when we look at the patient population in comparison to what we now have for onabotulinum toxin A, it is a much smaller group. It's not randomized, and the full data set is much smaller than the original starting point. And I do realize all of the difficulties in following such patients over a 5-year period of time. So I think there's definitely some useful information there, but I think we have to be somewhat guarded. This is the ICI from last year, and this publication just came out this year. There is sufficient evidence at a level 2 to 3 to evaluate implantable neuromodulation, but current series include a lot of retrospective cohort studies and no high-level RTCs, and there is a need for further prospective randomized assessments of this intervention. Now, the thing that concerns me is this is an intervention that's been approved around the world for 15-plus years, and we still don't have the level of evidence that I believe we should have for such a therapy 15 years later. I believe that onabotulinum toxin A is quite cost-effective when delivered in an outpatient or even office setting, depending on where you are, with local anesthesia. Over 80% of the patients in the phase 3 trials had their onabotulinum toxin delivered in that manner. I know what it costs in New York City. It's about, to the cost of the healthcare system is about $775 for a single treatment. There have been cost-effectiveness studies, which 2 of the 3 seem to favor botulinum toxin. The one study done in the Netherlands by Philip's group said that it did favor neuromodulation after 4 years, but it did assume in-hospital delivery of onabotulinum toxin at a higher dose than is now recommended. OAB is a chronic condition, and we all have to admit that we don't have very long-term safety and efficacy data on either therapy. As far as percutaneous nerve stimulation goes, I think we don't have the level of data that we need, and the trials were not necessarily done on patients with refractory overactive bladder. So I would maintain that with onabotulinum toxin A, we know how well it works, and we know the expected adverse events in over 1,000 patient study. We don't have that kind of data for sacral neuromodulation. I think it's cost effective compared to sacral neuromodulation in most healthcare systems, and I think it's easy for urologists and urogynecologists to perform, where at least I believe sacral neuromodulation should be performed ideally in centers of excellence. But patients must accept the possibility of needing to catheterize, and they must accept the risk of an increased urinary tract infection. They must be willing to have repeat treatments. We must take extra care in elderly patients and diabetics because adverse events are slightly higher. I cannot generalize these results to the OAB dry population at this time, so I truly am talking about an incontinent refractory overactive bladder. So I'd say it's not for all, but I think it's for most patients that fit those criteria. Thank you very much.